Hi, good afternoon, everyone. Welcome to today's conversation on emergency contraception at UIC. I am Natalie Bennett, the director of the Women's Leadership and Resource Center and the Campus Advocacy Network. Definitely let us know if you can hear us. If you're having trouble hearing us, signal in the chat and we'll project our voices even more than we are now. Thank you for being here today. Our conversation today about emergency contraception is actually placed in a larger context of reproductive justice. For us, we see full, equitable, and unrestricted access to reproductive health care as a key tenet of reproductive justice, which includes the right to have children, the right not to have children, and the right to parent children in a safe and healthy environment. So even before the 2022 Supreme Court decision in the Dobbs versus Jackson's Women's Health Organization case, citizen as well as political attention has shifted towards emergency contraception. Emergency contraception became one of the front lines for denying citizens access to reproductive health care and rights, as well as an area where we saw a lot of student activism on college campuses, from pushing for vending machines and creating alternative distribution mechanisms that put emergency contraception directly into the hands of students. So Illinois occupies a really interesting space in conversations about reproductive health care. We tend to see ourselves as doing very well relative to lots of other states, but we also have some shared concern. And so today we're going to be talking about the impact of one of the latest legislative acts, Illinois Public Higher Education Act of 2023, which requires that each public university make emergency contraception available for purchase through at least one wellness kiosk on each campus. So we're asking today, what does reproductive justice look like at and for a minority-serving public university in Illinois that is also connected to one of the state's largest healthcare systems? How does ensuring access to emergency contraception help us get closer to that vision? We're going to be having conversation about education and engagement, about what role pharmacists play in ensuring that emergency contraception is more accessible. Thinking beyond pharmacists, how do we make sure that people have the information that they need to be able to use emergency contraception safely? What else can we imagine about these wellness kiosks? What other work could they do that brings us closer to reproductive justice for our students and staff who will use them? So our invited panelists are going to weigh in on these questions as well as bring their own insights and perspectives. With us today, and in order that they will speak, Dr. Erica Hinz, Clinical Assistant Professor of Obstetrics and Gynecology at UI Health. Dr. Hinz is trained in complex family planning and is currently the Ryan Residency Training Program Director for UIC OBGYN's residents. Katie Kaczmarski, who is Clinical Assistant Professor of Pharmacy Practice. Dr. Kaczmarski is with the UIC College of Pharmacy. Her practice sites include the University Village Family Medical Center and the Center for Women's Health. In addition to her clinical work, specializing in primary care and reproductive health, she's a large contributor to the reproductive health curriculum of the UIC College of Pharmacy. Dr. Florestal-Kevelier is a clinical assistant professor of community health sciences in the School of Public Health. He has advanced training and over 15 years of experience engaging in scholarship, practice, and teaching focused on the well-being of university students, with an emphasis on its intersections with students' academic, professional, and personal success. But he's also the Assistant Vice Chancellor for Student Health and Wellness, most importantly for this conversation. Dr. Jenny Brier, who is Professor of Gender and Women's Studies and History and the Director of the Gender and Women's Studies Program. whose research and teaching are largely focused on exploring the historical intersections of gender, race, and sexuality. She's an active public historian working to make history useful and meaningful to communities beyond the academy. So each panelist will speak for a few minutes to the question that they think is particularly important for us to consider, respond to each other's questions, and then we open it up for questions from the audience. Audience members are invited to post your questions and comments in the chat, and we will share them with the panelists. So let's begin. Erica.
Hey, can you remind me the question, the first one you would like me to answer?
So I think
Very loud. Okay.
Yeah, so I think the core question that we want to kind of ground everything is that what is emergency contraception?
Okay.
And why should we be thinking about this at the university?
So emergency contraception has got a lot of myths and misconceptions surrounding it, kind of in the lay public and even among clinical providers. So I think I want to start off the bat by just saying that emergency contraception is a form of birth control that prevents pregnancy, but does not end a pregnancy that has already started. And so you may have heard people confuse emergency contraception and say things like the morning after pill, and then that kind of gets confused with medication abortion. And so what we're not talking about today, although it's very important, is medication abortion. We're talking about emergency contraception, which can come in the form of a pill. There's three different regimens that someone can take as an oral pill. And then there's two different devices, intrauterine devices that can be used. For the purposes of today's conversation, I think we're largely, when we say emergency contraception, talking about Plan B, because that is the only one that we can get over the counter or without a prescription currently. So I think that's just the clinical side of it. And again, I'm an abortion provider, contraception provider, and OBGYN. So that's kind of the lens that I'm coming to this with, but also a huge advocate for people to be able to access care in the easiest possible way for them. And I think this conversation is just so important. And I love that it's being driven by the student body to really take control over your ability as students to access this vitally important method of birth.
Thank you.
Katie? Oh, I'm next. Excellent. So coming at this in terms of how pharmacy can optimize education, access, and availability is sort of my perspective. In addition to the clinical work, I also participate on the Pharmacy and Therapeutics Committee for the campus care and student health organizations that serve insurances for our student population. In family medicine, that's the largest, I think, central provider for primary care services of our student body. So I have a unique kind of practice site in terms of we have a lot of stakeholders there that are wanting to ensure that we're providing support for emergency contraception access in the easiest and most accessible way. I think, as we'll talk about later, vending machine access for Plan B is excellent, has definitely shown in the literature to increase access of that particular product. But what I'm uniquely interested in is how pharmacy can support access through low-cost options. So as a reminder, as a part of your student health fee, all forms of emergency contraception are available at $0 cost sharing for the student, so free. So thinking about ways that we can preventatively and maybe proactively facilitate access points for students for not only Plan B, but also possibly funnel patients that would be better suited for our other pill option that's only available by prescription, might be better suited for some folks, find ways to improve access points for that. Pharmacists also throughout the community in Illinois are uniquely posed in terms of accessing or prescribing birth control, all forms of birth control that are accessible at pharmacy level. That rollout has been a little stagnant in the last few years, but a lot of really interesting kind of opportunities within the state of Illinois and certainly central in Chicago.
Raphael again, and I'm coming at this from a few different lenses. So on the one hand, coming at this from the lens of some of the work that I'm doing nationally to advocate for reproductive health care on college campuses. But what I'm going to speak a bit more about today is how we as an institution are starting to respond to the new legislation about accessing EC on campus through vending machines. And so I think in addition to the notes about the resources that are available through pharmacy, some of the key components of the legislation is to ensure that there's access to EC at low costs in locations that are accessible after hours, and so for our community. And so we've been on a journey at UIC to get to getting these vending machines off the ground. And so we all, for those who have been to our Student Center East and our Student Center West, you may have seen other health kiosks that are kind of managed by CVS Pharmacy. While those vending machines have existed and have offered EC through them, the price point has been extremely high. And when the legislation came out its first iteration, the price point was above what the legislation would allow. And so while we have the CVS machines, we are looking for an alternative solution for providing not only EC, but also other safer sex materials, but also using those machines to do some education, provide some education about reproductive health, sexual health, and about where students and community members can go to get additional support and or education once those things are implemented. And so for the kind of educational plan or communication strategy, there have been some initial conversations with colleagues like Dr. Brier and students who have been fierce advocates for this work even before the legislation came through, about what that launch could look like, what education could look like, how we could leverage the machines that we use to do some of that education. But in terms of getting the machines off the ground, there's a collaboration that's happening between my team in health and well-being and student affairs, my colleagues in the College of Pharmacy, my colleagues in student health services and family and community medicine, and also auxiliary services within student affairs. Auxiliary services is procuring our machines right now. So we're working on getting the machines placed for this first phase to get it out as soon as possible in those two locations that the first phase would be in Student Center East and Student Center West. There were some surveys done with students to kind of identify the most appropriate location that they would feel comfortable engaging with the machine on, and those are going to be the locations that we choose as the first place. And the Wellness Center and my Public Health Initiatives team, that's a part of my team, will be helping with restocking the machines, creating the educational content. And when I say restocking, in addition to the EC component, restocking with condoms and other safer sex materials, and staffing the machines. And then College of Pharmacy is going to help us procure the EC that's going to be in those machines as we kind of go with this first phase. And when I say first phase, these first machines that we're using are not going to be particularly high tech. They're really just getting it there out so we can actually increase that access. And as we're able to as I'm working to advocate for additional support and resources, there are several vendors that have very helpful machines that are very high tech that kind of help that have a lot of functionality for additional ways to educate the community that would want to be able to put in place that have QR codes and everything that will be able to use. So that's kind of where we are today. The goal is to have it as soon as we get the machines procured, which that's the part we're working on. It should be launched within weeks, like 1 week or 2 weeks. That's
well, thank you for Dr. Bennett for inviting all of us together. And I'm just sort of struck by the way the dialogue, even in these first comments, have sort of expanded out into lots of different ways, because part of what I understand as someone who is not trained in public health or in medicine, but trained in history, like I see things in those circles. And I think that really helps. So I put in my notebook, what is EC? And I circled E first, and I have some little bars that go out, and then I circled C and I have some bars that go out. And I think that that is really, for me, just, I can't see your faces on the Zoom, but I can see that there are people of lots of genders and lots of age ranges and lots of other sort of diverse questions. And so what EC means to a cis-born woman who is in a relationship with a man and has had, or in an ongoing and consensual relationship with a man, as well as unfortunately the reality of a not consensual relationship with a man. EC means one very specific thing, and that thing is important. It is what it's what the medical doctors here have told us about. But I think emergency contraception as a concept is important for all of us to understand. Both men, women, non-binary people, people who can get pregnant, people who can get people pregnant, all of these things, they matter. And so I guess what I want to say is, for me, the important thing is to think about the contraception part and what gets defined as an emergency part. And if we think about that, meaning and not to lose track of what we've heard is important about what Plan B can do for a person swallowing the pill, right? But also to recognize that what emergencies are much more expansive than that. And we know that on a campus like this, in a city like this, in our world like this, in all of these things that are happening to us, some things you can get in a machine and some things you can't. And we need to be talking about what the relationship is between all of these things if we're really going to, as Dr. Bennett said, if we're really going to take seriously what it means for this campus to have a commitment and live it out in relationship to reproductive justice. We have to be prepared to have Plan B freely, or as close to freely available as possible, 24 hours a day. And we have to be prepared to understand what the kinds of emergencies we face, or the kinds of reproductive injustice and sexual health injustice we face, and how we can navigate sometimes biomedical solutions and sometimes pharmacological solutions and sometimes social and public solutions to those things. So I'm really excited to think about that together.
Do any of the panelists want to respond to what we've kind of put out so far?
I don't know why, but the word emergency, and I'm seeing Jenny, Dr. Brier's little stick, but you can't all see it. There's a circle and like what looks like stick figures.
Yeah.
But the word emergency keeps coming to my brain because I feel like what we are currently in, and it's been in a public health emergency. The state of reproductive health has been in a state of emergency for many, 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 many years. Like the Dobbs decision was just something that accelerated it. And so when I think about emergency contraception, I think it's just one component, very small component, but very important component of how we, as a public health, from a public health perspective, are responding to being able to help people, going back to the definition of reproductive justice, plan if and when and how to have a family. And so I think this idea of emergency that Dr. Brier brought up is really important, because I do think that we are living in a state, we, the collective, as a society, are living in a state of emergency all the time. And so you may see us all being a little stressed out because of that. But I think solutions like this, bringing in the social aspect, the public health aspect, are so important, especially on large university campuses where we're all very different backgrounds up here, but care about this issue so deeply. And that just goes to show, I think, how important it is.
So the question that I'm kind of led to ask, what is it that is preventing us from realizing some of these changes? What are the kinds of obstacles that we need to kind of confront very directly? Yeah, so I'm like, let's just go directly to like the punch, right? Like, what are the obstacles that we need to really kind of name and address, kind of think through and activate around, in order to kind of realize these changes, I guess?
I think there are a few, but one that I feel like if anyone has heard me speak before, and if some of you all may just know about the decentralization of UIC, and what I think, I'm coming from a public health background, I'm thinking about systems, I'm thinking about the various ways that can get at addressing an issue at all levels and who might need to be at the table to kind of see it through. And I think, you know, when I think about all the other health and well-being work that I'm charged with doing and excited about doing here, some of the challenge that comes up is the need to collaborate and coordinate our response efforts. So even as we think about this implementation of this kiosk on this campus, there are a number of players who are involved in implementing that, who may not have always historically worked together in other scenarios. And so the muscle around collaboration hasn't been exercised, and it's being exercised now. And so being able to create more spaces where we like you said, we have all these different backgrounds on here, but how do we get those like-minded folks at the table in a way to come work towards a shared vision and like have those complementary activities going on to reach that ultimate goal of enhancing access, and not just from the level of making sure it's in the vending machine, but as we kind of work towards upstream advocacy for shifting in policies, because there's when I think about reproductive healthcare, it's a broad continuum. And I know the last time I was in this room, we were talking about our students who are parents and supports for them, and making sure that though we're providing those resources and supports to all of our community members who are navigating these different scenarios.
Yeah. I think I want to plus that and also say that I think it's something that, Natalie, that you said at the start, that Illinois is a paradoxical place. So I mean, we could probably generate a quick list of some of the paradoxes, but let me just say a few that I have on the tip of my tongue. It's a blue state where Chicago is very different from the rest of the state, and a kind of antagonism with Chicago that exists in a lot of different contexts. And there's and then Chicago itself is an incredibly segregated, historically, racially segregated city. It is a place with, but it is a place with a democratic machine and a blue state, which might be different. It's a place where right now we have a governor who is fully, and a lieutenant governor in particular, who are fully unafraid to express their support for reproductive justice. And then when we get to the University of Illinois, there is its own set of paradoxes. So UIC exists in a system where, and our colleagues here who work at UI Health, like those are two different things, which I've learned more about than I would have ever hoped, when I would have ever understood. But UIC and UIUC are very different places. So this is something that Raphael and I have talked about in other contexts. We don't have a health service for our students. We have campus care, which is a very different system than what might exist in Urbana, and certainly where I went to college at the University of Wisconsin-Madison, and even graduate school at Rutgers, big public universities, different models of taking care of our students. And then I think there's the reality that all of these things are in place for UIC to be like, that you have these 5 people on this panel, that says something incredible about UIC. And I don't know that we're always so proud of it as an institution. And so I think we do the things that we're told we have to do. And I don't know that we I don't know if we're in the place yet where we're gonna be able to do the things we imagine. And the paradox is we can still imagine all of the things that we want to do. And that's really exciting. Like we can imagine all of the things and we can get told no and we can keep imagining until we get told yes.
I wanted to add on to plus all of that. I think I have learned so much in the last, since we started working together as a group, since the DOPS decision. Just as background, you know, in June 2022, we were all devastated and dealing with that kind of big decision in various ways. I can't even remember how we all came together. But
It was in April at the league.
April at the league, yes. And we started talking to one another across campus and just saying, like, what are we going to do? How are we going to support not just abortion access, but make UIC, UI health, the whole UI system prioritize reproductive justice? Because I will be honest, as it stands right now, and I've learned a lot more than I ever imagined in the last year and a half about, or almost 2 years now, about how the system works. But we just don't. We're not prioritizing it at the highest levels. And I think all of us have come together to really say, like, I think we need to be at the forefront and knocking on every door and talking about it all the time. And we sound like broken records, but it is so integral to our communities that we serve, to our student community, to ourselves as faculty members, that we talk about it and that we talk to our leaders that have the ability to make the big changes. And so we're learning the systems, I think, as a group and learning how to navigate that a little bit better. But we are much stronger when we come together and kind of break down the silos. And I think that's the biggest thing that I've learned over the last couple of years.
And I just wanted to add one tiny thing. As we've kind of all been talking, a couple of things have sprung to mind, but I can't tell you how often I interface with students, quite often, both in my clinical work and on campus, and how often they're unaware or unsure of how to navigate systems, because I know that campus care is its own kind of, you know, thing. And then you've got what's covered under student health, and neither the twixt shall meet, but they're all coming from the same place. So encouraging and in efforts with this, these other kind of priorities is encouraging and supporting student advocacy and self-advocacy in this realm. I think there's a lot of stigma and perception in accessing not only emergency contraception, but like breadth of reproductive health. So normalizing and creating great access points. Growing pains that we've seen not in the pharmacy kind of realm is just the lack of access on those out of hour times, weekends, times when students would benefit most from accessing emergency contraception and other healthcare. So long-term, figuring out if that's a possibility to expand and support as we think about our efforts here.
Do you think, though, that the maybe this is a question for all of you, that SB 1907 is that's the number, right?
Yeah.
You have it there. I'm just cheating and looking over your shoulder. My sense is that I guess I would like to see, to Erica's point about the communities that inhabit this place, like those vending machines are not just for students.
Yeah.
Those vending machines are for housekeeping and faculty and graduate students and the trades and academic professionals and civil servants. So it is also like naming the fact that I think it's complicated because this is a place where people learn and and some of our, like a big chunk of our work is about teaching and learning. Then there's this part of our work that's about research and scholarship. And then there's this part of our work that is about service in a much more capacious sense. So I don't know how that works for staff on, like, how do they access the pharmacy I mean, obviously everybody has insurance if you work here a certain number of hours, et cetera, et cetera. But what are the other sort of public facing things that you do that are maybe apart from that, or am I just imagining something?
I think what I see as the like functional difference with students in terms of access is any of their access points has to be under the umbrella of UIC, so they have to use our pharmacies, they have to come here. There's limited clarity on how, if they were to purchase emergency contraception at CVS, how they could potentially get reimbursed,
Right.
because it's covered under student health, not campus care, so it's within their student health fee, and so there's not really a clear mechanism on how to do that, whereas faculty or other staff members have typically either employer-based healthcare or other types of provided care where they can go to a Walgreens or a CVS, and the pharmacist is allowed to create a prescription for birth control within the realm of some or for EC and bill it under their insurance without cost. So there's a little bit of different
Yeah.
nuance for our students, I think.
No, I think that's a really important distinction to make, because I don't know how many people on the Zoom are students and how many are staff and faculty, to just sort of acknowledge that even in our own community, there are real differences.
Yeah, as I was kind of thinking, there's a really great point that you raised, Jenny, because as I was thinking about this, I was like, but access, when we're thinking about access, we're beginning with students, but really we need to think about who our larger community is.
Yes.
And who is here, who is using this institution, who is like servicing this institution. So that brings me to the another question about education and engagement. Based on kind of what we've named here in terms of not only who will kind of use the emergency contraception, because we know that it's not only going to be students, and the kind of obstacles that we've already started to kind of name. What does the education and engagement kind of need to look like? What does this context kind of require of us, kind of demand of us, if we're actually going to kind of move closer to making sure that there is like full access to emergency contraception? What does it require of us?
I think it's a full-blown kind of public awareness campaign.
Yeah.
I don't know what else to say, but other than posters, email blasts, things in the bathrooms, anywhere people might interact with the system as a whole, both East-West campus, outdoors, having events where we kind of talk about it. Because access is great if we have it, but if nobody knows about it, then it won't be utilized, and then we might not have a sustainable system. So yeah, some sort of like public awareness campaign, I think, would be really important.
And I'm also kind of thinking about the content. What do we need to gain?
Yeah.
So I know there's, of course, where the resources are available. But I'm also thinking about what is our role in educating students about their rights and self-advocacy, particularly with such a significant commuter student population and a significant international student population. Our students aren't always here. They are in other locales. And whether they're in Illinois or not, what are things they need to know about knowing that this federal decision was made, and decisions are being made at the state level? How do we make sure, outside of talking about safe first acts and talking about reproductive healthcare and what's available to them and where they can get access to it? I think there is that advocacy, self-advocacy, and also kind of knowing your rights piece. And then I think even for us as providers and supporters or student-facing folks who might be involved in providing care, making sure we're aware of the changing landscape, which is complicated, but trying to track with that so that we are making sure that we're giving our students or end users the right information or the as accurate information as possible about how they can navigate access regardless of where they are.
So the only thing I would add to that is that, and I've been thinking a lot about this, not just from this conversation, but from the world and the state of things, such as it is, how much listening is required for engagement and access? and this is my own, like, I'm calling my own self out. Like, I am a purveyor of information. I'm the mother of a 14-year-old and the chair of an academic department. I am a purveyor of information. And I need to work on being a listener to what people say after I purvey that information. So I think access requires of us being able to listen as much as we're able to share out. And that then means it's a whole set of things that we can't quite predict yet. But if we have the commitment to that, and the commitment to being able to change our course based on what we hear and the speed in which we hear it, which we know is never linear and straightforward and always one direction. So it requires an ability to listen and a willingness to actually adapt, because access doesn't go in one direction.
And I think to expand on that point, that the access for emergency contraception in this type of instance is not the end of their journey
Correct.
with which to kind of continue. So in prioritizing how a student or a faculty member or someone who's utilizing a service can then know how to navigate next steps
Yeah.
for either future contraception, STI testing, you know, this, that, and the other.
I think that brings me back to something that you mentioned, Raphael, about how you were imagining these machines, vending machines, kiosks,
Yes.
whatever. What do they call them?
Machines.
I have so many items that I want to put in them, I can't even tell you. I have imagined so many things.
So let's talk about that. Let's talk
Okay.
about the thinking beyond emergency contraception. And thinking in tandem with emergency contraception.
Yes.
What other work do we imagine these kiosks or these machines doing for us, for the community, that kind of gets us closer to the vision that we have?
Well, I think one, and I'll start, I'm sure please folks weigh in. I think it's based, like, where they're going to be located, it's going to be interesting. I think to your point about, we had this discussion about the fact that it's not just going to be students who are accessing these machines, and knowing that they're going to be available after hours, like anyone. This is a state institution, as long as those buildings are open, you can come in and use it. But some of the initial items we're thinking about, since again, this is a low tech machine, we're probably going to have like 3 items, 3 rows of things, but of course can expand, but we'll have EC. I know currently the Wellness Center puts together kind of these safer sex material packs that are condoms, pleasure parallelograms, as I like to call them, and lube, etc., and some QR code that directs to some additional information about these resources, where you can get them here and or in other locations and how to use them. So in little baggies. So they're going to be putting those together as an item. And if I recall correctly, I'm not going to put her on the spot, but if I recall correctly, I think one of the other items may not necessarily be about sexual health. It's going to be about something else, like just health care and well-being in general, like whether it's Benadryl as an example. And I think some of the thought behind that is like, this is for overall health and well-being. And so we don't want it to be the machine that you're going to, it could be that if that's what folks wanted it to be, but we wanted folks to see it as a kiosk and or vending machine where you get your health and well-being materials through another access point. And like I said, because they're low tech machines, we're probably going to fashion it with QR codes that can scan that directs them to additional information on the machine. But one day we're going to get those really cool machines that has it all.
Robots that deliver, like,
Yes, that.
So I love this question so much. I love this question
But everything.
so much. And I really actually would love I don't know if people feel like they can, but even just as we're talking, if you on the Zoom have ideas for what you think belongs in a machine, if you could just load them into the chat and then we could talk about them. I think that could be really exciting. Get some creative juices flowing.
Crowdsourcing.
What?
Crowdsourcing.
Some crowdsourcing, yeah, totally. I keep thinking about, I don't know if others of you have been to these, there are a couple of them around in places, old, and this will also date me, old cigarette machines that have been converted into art machines, artomatics. And you can put $5, which is I think even less than what it costs to buy a pack of cigarettes now. And artists have made small pieces that you can have. So I think we should have an artomatic in the EC machine, or maybe so either some kind of artomatic or something that allows you to make your own art that is related to reproductive and sexual health, maybe emergency, maybe it'll be whatever, and it'll just have some things that you can, like a paint by numbers or something like that. I think the idea of having things other than the EC, and as my students would say, a penis condom, not a, right, they actually really deeply like want to understand how, and they wouldn't even call it a woman's condom because they're very sensitive to the realities of gender non-binariness, but a vagina condom, like all of these things, an interior condom and an exterior condom. So I think in addition to those sorts of things, Benadryl and other kinds of things, of course, we know that there are menstrual products in most bathrooms around campus. So we may not need them in that machine, but that would be an important thing. I think, you know, different mechanisms for doing different kinds of educational outreach in that machine. So when we get the pill over the counter, the pill needs to be in the machine. When we get, I don't think we ever will. When we get PrEP, so PrEP is, for those of you who don't know, pre-exposure prophylaxis. It's a way of taking a dose of an antiretroviral medicine, which then means that if you are having sex in a serodiscordant couple, meaning one person is HIV positive and one person isn't, it's protective. So that is we need to acknowledge that some of those medicines have been tested more on men than on people assigned female at birth. We need PEP, which no one really talks about at all, which is post-exposure prophylaxis, which is a totally different regimen of drugs that you take like a Plan B, but to prevent infection with HIV. It's an insane regimen, 28 days. Pretty clear that it doesn't need to be that, but that's another story. And then I think, I think a space for imagining needs to be in the kiosk. And it needs to be something where the crowdsourcing is real. And I think it needs to have then like lots of information, like go to the pharmacy, go to the, or come to Campus Advocacy Network. If something like, which is where we are now, I think those sorts of things need to be in it. And then I think, some tissues and, stuff like that.
Just gave me a good idea on the crowdsourcing, because we intend to evaluate utilization of these machines.
Yeah.
But I think a good piece will be looking at when you get there and something's missing.
Totally.
Tell me,
Right,
let us know.
Yeah. I will say, as someone who works on primarily the West Campus, I don't think that most of our bathrooms have menstrual hygiene products.
Oh, they don't?
No.
No, that was
Never.
Are you serious?
Yeah, no, it's bad. So, it's probably much better here on the East Campus, and I don't know why that is, because we're, clinicians mainly.
Because
That's
a lot of
just-
menstruating people.
And lots of menstruating people are the department of 70 plus, menstruating people, 70%. And so we don't have that other than like the pads that we give to our patients. But for us that work there, we don't have that. And
Oh, okay, so
So
that's like a problem.
Huge
because-
problem,
Because
yeah,
the
just-
institutions actually require
exactly.
to
So
actually,
Oh.
yes, it's actually required to provide them.
yeah,
And it turns out that it's actually very easy to actually have one installed.
Yeah.
But you have to ask. So they set it up so that you have to ask, that they're not actually gonna do it unless you ask. Interesting. Yes, I found that very interesting as well.
You were gonna say something else, though, I think.
Yeah, sorry to interrupt you. Yeah,
no,
yeah.
oh, just obviously people access EC for many different reasons, but
Yeah.
one of the primary reasons is after sexual assault. So I think
Mm-hmm.
having resources available to let people know where to turn and where to go when they feel ready to do that is going to be really important because many people that have been assaulted are not going to feel comfortable right away, but this is a good entry point for so many other resources.
Right, the EC is the first step for that emergency. And then there is a larger crisis that comes from that, yeah. And just for everyone on the call to know, like, that, this is one of those places, where we are right now, the Campus Advocacy Network is housed in this building. But Natalie, maybe you want to say something.
So there are kind of two directions I wanted to go in. One is, and I think related to the existence of a campus advocacy network at UIC, which is so those of you who don't know, it's provides both crisis intervention and advocacy and support for survivors of gender-based violence, as well as provides education for the campus around like violence prevention. And so we are, for many people, we are one of the first places that they turn to in disclosures, to make disclosures about harm that has happened to them. And we walk people through the various kind of iterations of their healing process. Some of that includes interfacing with the institution through Title IX processes. Other parts of it includes figuring out issues around housing, around mental health care, around kind of getting financial assistance. So we do a lot in terms of supporting survivors through their kind of healing process. So that actually, you're raising that question was making me think about what we don't talk about when we talk about emergency contraception.
Yeah.
And so I wanted to kind of open that up with like,
Yeah.
what gets left out of the conversation when we're talking about emergency contraception.
That's a deal.
I like the other one better.
I think it comes, so obviously gender-based violence is a big topic that I think, we don't always talk about in relation to emergency contraception, but also just the lack of access to preventative care in general, right? So someone who does not want to be pregnant is having unprotected sex that can get them pregnant and then ultimately needs emergency contraception is a person that also may want longer-term preventative medications to prevent getting pregnant, and then also entry into the larger reproductive health care system. So I think just thinking about that, and also from a provider perspective, there's many, many, many studies out there that show that we are the limitations. A lot of the times, the pharmacists, the doctors, the nurse midwives, the people that are prescribing or providing this medication are not always thinking about it and talking about it with their patients because it's just, for many reasons, stigma, just lack of education and knowledge about the laws or what's changing all the time in reproductive healthcare landscape, but also just amongst the other things that we're trying to get through in a 15-minute visit, sometimes this gets left by the wayside. And so I always talk to people when I see them for any sort of family planning visit and say, hey, I'm going to prescribe this for you because sometimes it might be cheaper with a prescription, sometimes it's cheaper over the counter. And even if you don't think you need it now, just go pick it up today, put it in your nightstand so you have it. And so it's when it does happen that you need it in an emergency, you're not scrambling around to get it. And so kind of thinking, forward thinking, I guess, preventative thinking instead of reaction.
One uncomfortable kind of piece that I think about when talking about this is pharmacists themselves, in addition as being the functional barrier to access on purpose. So thinking about within various states, there's different what we call like conscience clauses of how they can, how a provider can choose to not provide care or not dispense medications. It's an ethical discussion I have with students in my lectures as well as on rotation, but having students and other faculty and persons understand what their rights are and how, if, you know, a lot of times community pharmacies in more rural communities or outside of, or even within the city of Chicago may decline to dispense emergency contraception for personal health beliefs. Within the state of Illinois, it's required that that pharmacist facilitate that patient's delivery to another provider that will dispense, but that's not always done. So I think in a larger conversation as our professional and responsibility towards this effort is having those hard conversations on those issues.
Those are really, I don't know that I would have thought of all of those. That's pretty interesting to me. I guess for me, as someone who no longer can get pregnant, I also want to sort of name that what a reproductive justice lens gives us is a way of understanding how some of those things that you do are also complicated. Like every time I go for a medical procedure, I'm told I have to take a pregnancy test. I'm like, I haven't had sex with a man in 30 years and I am in menopause. Like, I promise you, I don't need to take a pregnancy test. So part of it is like, and I say that just because I don't think that we have enough belief in people that they know what's happening to them. And that's, for me, a fundamental, that is an emergency. That we don't believe people when they tell us, when they know what's happening to them, what they need. And we have other, you know, so I think that that is really, I think that this conversation at the very basic level of what we miss when we talk about emergency contraception is potentially we miss, I don't think this group misses, but I think what we're suggesting is that all of these things always need to be understood in a context of reproductive justice, whether it's access to abortion, whether it's EC, whether it's contraception, long-term sterilization, sterilization abuse, and decisions to have your tubes tied. It matters that that people assigned male at birth be understood as having reproductive health and requiring emergency contraception as much as people assigned female at birth. It means all of these things. So I think it's kind of, again, maybe I'm back to my kiosk and imagining the things that you would do, but it is an imagination space. It should be, we should be inspired by that potential and not deterred by it. It can be a creative space. It doesn't have to be a detrimental space.
I'm going to pause for a moment and invite our participants or audience to share questions, comments that you'd like the panelists to kind of respond to. We'd welcome that. I don't know if we have any questions so far. We have a few.
Yeah, we have a couple. One of them you already answered in your conversation, so that was great. Although I might just ask if you have anything to add. So our first question, one of our first questions was about who the machines on campus would be available to. And so I think Jenny and Raphael, you kind of clarified, these are available to everybody on campus?
Yeah.
Yes, yeah, they would be able to access, it would be in a public space.
It'll be in a public space. Okay, so actually the public, if
Yeah.
somebody new and wanted to come onto campus
While those students are open.
while the student centers are open, okay? So the machines, so for instance, in Student Center East, the machine would not be in the wellness center. It would be in a more
It'd be in a more public space.
public
outside.
space. Okay.
And then that's badge access after hours or no?
I think it
I
locked.
think it's just
It's
locked.
Locked.
after
Got
hours.
If it were in the hospital, it wouldn't.
Yeah.
Of course.
Okay,
Having
thank
been
you.
in the main atrium of the hospital would be amazing.
I think it would
Yeah.
be amazing.
Another question we had earlier on in the program was, I know there has been a push to stock up on emergency contraception.
Yeah.
So I was wondering if you can speak to whether you recommend that approach, or if there's any advice you have for keeping EC on the shelf at home safely and not letting it expire, or anything else detrimental can happen to it if it's sitting around for a while.
Like the pharmacy thing.
Yeah, I think twofold when I think about this question. I think in terms of, that's how I would encourage folks, especially if they're on a tight budget and maybe are unable to afford something that might be $10 or $20 in a kiosk. That prescription can be filled under their student health coverage. And that would be the best way to access because the pharmacies are so inaccessible outside of business hours. And so just keeping that at hand. I think what I would caution against is reliance on emergency contraception as a longer form of birth control. And perhaps that could be education, embedded within the kiosk on, if you're here, think about, ways to access longer forms of contraception.
Yeah, it's not that it's not dangerous from a clinical standpoint, it just doesn't work as well. And so the other thing we should put on there education wise is when to take a pregnancy test, and that people, your menstrual cycle will change most people's will change after taking one or more of the Plan Bs. And so one might think that some spotting is their menstrual cycle when it's not, and they might actually be pregnant if the emergency contraception didn't actually work. So making sure that we educate people for the signs of when it doesn't work, so know that they're actually pregnant. And again, there's nothing dangerous inherently about it. And when you look at the scientific data to say, are there any reasons why someone could not take Plan B? There's not a single one. There's really no contraindications at all. However, it's not the best, most effective long-term, like Katie mentioned. And the one other very clinical thing I wanted to mention is that there's lots of evidence coming out now that body weight has a lot to do with how effective Plan B is, specifically the levonorgestrel pill. And so Ella, which is the other pill that requires a prescription, I really think we should shift our focus a little bit more to getting that over the counter because and accessible, because that does not rely as much on a person's body weight for efficacy. And so long-term goal is get Ella in there too.
Yeah, absolutely.
And then we had some audience suggestions for things to put in the machines.
Let's hear it.
Crowdsourcing begins.
So health info in zine format.
Love it.
Our
Love
friend
it.
Veronica. Also art machines, poetry, short
Yeah.
stories, all with exclamation points. And then along similar lines, before you had said it, rape crisis info, right? So info about our campus advocacy network and other resources in the community. So yeah, a few ideas there.
Love it.
Yeah. That's all we have right now.
Other questions that folks have? Or are they allowed to come off mute?
Yeah, so you
I
can
told them.
come on, yeah, you've been invited many times, come off mute.
Come into the room.
Come into the room. Yeah, ask your question.
No.
No? Okay. So,
Obviously, we can keep talking for a long time.
Listen, I can be a chatty guy.
yeah, I mean, I have many
I
more
know you do.
questions, right? But I think that I wanna ask, so what happens when we get these things that we say we want.
Yep.
What happens when the machine comes, and maybe we could give us a timeline for like when these machines are gonna appear, if you know that, that would be great. But what is it that we imagine is gonna happen once we get these things that we're asking for right now? What's going to shift? What do we want to kind of shift in an important way?
Well, I don't have a timeline yet, but I know soon, because the thing that's driving the timeline is once we get the machine. So that we have someone in auxiliary services getting those done. And once that's
Well, let
done-
us know if we need to put pressure, because we
telling you.
could definitely help with that.
So I don't think this is a pressure point at this point. The pressure would be getting the additional resources to buy the fancy machine.
Okay.
That's where I would pressure.
Okay.
But what do I mean, for me, I want increased access. Like, I mean, the whole point of the conversation for me is increased access, but also raising awareness about what's available outside of this us too. Because it goes back to some of my, drive of this work is clarifying and enhancing pathways for students, because there are so many resources, but it's not always clear about how to get to them. So I see it as a starting point it's going to be a resource, and I think a starting point for continued engagement around these topics, depending, and it could be a conversation machine, that crowdsourcing thing.
People gather.
Right.
Oh, and just like hang out. Yeah, off of each other.
Right.
I think, oh, go, you go.
I just, logistics question, longevity and sustainability of this, like how do we see that going, and like funding for this and stocking and all of those things?
Yeah, so right now, the plan, so we're getting the low-cost machines, we might be getting the dope. So that's a thing, which is why they're low tech. But we are going to
You get cigarette machine.
listen, but we are going to be charging, but a very low fee. Because I know Urbana-Champaign is for free because of how their health organization is oriented in terms of their funding. But it's going to be a very low cost. We're trying to get it no more than $10. But the reason for the fee is to kind of help back restocking, but also kind of, in essence, pay for that the restocking process, the product and the human is going to be restocking it. So the goal is not for us to incur additional expenses, just to be net neutral. But if we were to have the fancier machines, there would be an annual cost for that we'd have to factor into our budgeting process with the LB.
This might be a dumb question.
Yes.
But the low tech machines, are those like the little spiral ones?
Yeah, it might be a little spiral.
So like,
I know we're looking at sizes of boxes.
right, I was
Yes.
gonna say, like, what if something gets stuck or it gets caught as it's dropping down?
So there's going to be a way to contact someone. Issue on the machine.
Cool, then comment.
Or pick.
But part of it is also one of the reasons we're working with pharmacy is because we'll probably be able to get test items to see what fits
Yeah.
in the coils of the machines that we'll be using. But the other part of this whole first phase of process of using the low tech machines is to actually evaluate utilization, to be able to use the metrics that we like to advocate for more support or resource for expanding, whether it's more updated machines or adding to more locations than what we're starting, which is considered east.
I would just encourage you, Raphael, to make sure that you have capacious metrics.
Yeah.
So that it's not just how many ECs have
Oh.
been, no, I'm just naming that as like a sort of to say like, coming to the machine is an engagement with the machine.
Right.
Getting Benadryl from the machine is an engagement with the machine. Getting your Artomatic is an engagement with the machine, because part of what I would hope we would get when this happens is a recognition of the reality of our lives.
Mm.
And so, it's both about making sure that there's access to EC and safer sex and Benadryl and tissues, but it's also about, like, when Erica just said, I don't know if those of you on the Zoom could hear it because she said it. She was like, that we all just are like meeting at the machines and talking at the machines.
Right.
You know, and that is not a metric that you would necessarily be able to measure, but maybe it is, if people who are restocking the machine also spend some time with the machine.
Yeah.
And, you know, many of us are trained ethnographers. Like there are lots of ways to understand how to measure the engagement with the machine.
Oh, yeah, yes. Never one who just sits on process metrics.
Yeah.
But also, Jenny, if we get the fancier machines, they might have the AI technology.
There's some fancy
People
machines.
just standing around, but yeah.
Well, if we don't have any more questions, I'd like to thank, no more questions?
No, I was gonna say, I also just posed to everybody in the chat, like, what do you all think? Do you think people will use these machines that are out, sort of in public and in both student centers? What ideas do you all have for getting the word out about them and about reproductive health in general, right? So that people can be informed users. So I'm just gonna I've now said it out loud, just put that out to everybody. Like, if anybody has any opinions or thoughts to share, we'd love to hear them.
And we're gonna continue to kind of ask your opinions about this question. We have, in our newsletter each week, we have weekly questions that we can do a poll. And so there'll be different kinds of conversations that will come out of this conversation today. And I'm very thankful that all of you joined us today. So can we thank all our panelists?
Yeah, feel free to come off mute and say thank you or,
Yeah. Thanks for listening in. Thanks for sharing your questions. Thanks for taking this issue with you wherever you go. And we look forward to seeing you at the next event.